Well, good morning, everyone. Those online and those in the room. Really pleased to look at today's grand round, improving rescue responses for patients with surgical complications. The Respond Human Factors Study. The QRST group is led by Professor Peter McCulloch. Peter was originally appointed as reader in surgery in Oxford in 2004 and a full professor in 2013. He graduated from Aberdeen University and underwent both his surgical and academic training in Glasgow, and was then appointed senior lecturer in the tough environment of Liverpool University in 1992. Peter chairs the Ideal collaboration, and if you haven't read it, definitely worth reading the original papers from Ideal and the subsequent work. That's an initiative to improve the quality of research in surgery. And then the QRST research group, which is dedicated to studies of quality and safety interventions in study. This group has been asked to provide human factors training for the General Medical Council and more recently to assist with the response to the COVID pandemic. So it's a great pleasure, Peter, to welcome you and your team today to see how you've been doing with the response study.
Ashok, thanks very much. Good to see you again in the flesh. So good morning, everybody, including the valiant few who've battled through to be here in real life. As Ashok says, Respond is about trying to reduce the death rate from surgical complications. And we're going to present this as a team. Dr. Laurie Earl, Saydia, Wesley, and our Johns Hopkins Research Fellow, Olivia, Lounsbury, are going to share the presentation with me. And it'll be in several sections. So I'm going to start with Laurie, who's going to explain the background, the theory, and the plan. And then I'm going to say a little bit about how we implemented this study over the last year. In the last year, we've been doing the pilot study in 3 sites, and implementation has been a challenge. We're going to follow that with Saydia, who's going to explain some more challenges about engagement and getting clinical staff on side. Before we look at the responses we made to all of those challenges and then go on to results in the future. So without further ado, I'll hand over to Laurie, who's going to explain what we thought we'd do.
Hi, thank you for welcoming us here today. Thank you, Peter, for the introduction. I've been with the team about 3 years now, so I'm going to take the first bit, how we came to the study, some of the problems we came across, and our plan. So let's talk about human factors first. What's human factors science? And it is indeed a science. I remember giving lectures to very crusty aviation airline captains, and they thought this was just fluffy stuff. But it is actually a science. It does involve robust and measurable methodologies that we use within it. It takes into account all those human strengths, which we're going to talk about as we go through this presentation. And we've introduced Safety 1 and Safety 2, which may be familiar to some of you. So Safety 1 was the original human factors that we looked at, where we predict and we learn from mistakes that happen. As human factors experts, we hate the word error. And then we moved on to Safety 2, where we looked at what we do right, which we do right most of the time, and where we learn from successful adaptation, resilience, etc. Essentially, it's a mix of the two. We still need Safety 1, and so we use both methodologies in the response study. Here in healthcare, it's been adapted with what we call a SEEPS model, System Engineering Initiative for Patient Safety. And this was put together by a clinical support group, as well as the CIEHF, which is the human factors group within the country. So I'm going to talk about the human factors approach, what we've learned and what we can learn and what we did for the study. So what have we already learned? So Professor McCulloch and his team has done quite a lot of research in this area, and we found that teamwork training can enhance team interactions, but we found the evidence of patient benefit is weak. So essentially, teamwork training, CRM, fetched from aviation isn't human factors, it's teamwork training. And all people tend to just look at teamwork training as human factors. We looked at, or Peter's team looked at quality improvement, which combined with human factors can be very effective, gives us better results, it enhancing engagement with that QI process. But overall, we found, whatever we did, staff engagement remains that #1 factor to determine the success of any project, and that requires specific attention, and we'll talk about that in this presentation. So, how can we make the difference to surgical outcomes? What do you think the most dangerous operation is in hospital? You might think cardiology or brain surgery or something, but actually it's an emergency laparotomy. Average, according to NELA, figures of mortality is about 11%. So why is this most dangerous? Well, patients are acutely unwell and possibly chronically unwell as well, but factor in things like an unfamiliar team, less experienced surgeons, fatigue, less access to imaging, etc. And this is where we get the problems. So systems problems are often best addressed using a human factors approach, and that was the conclusion we came to. According to Deming, 85% of the reasons for failures are deficiencies in the system. So we're looking at a systems approach rather than just the individual and telling them just do better. So let's have a look at some of the system human factors based challenges. I'll let you look at those on the screen. I'm not going to go through them all, but I'll just pick a couple out. So we're looking at deteriorating patients, failure to rescue. So how could that work on the ward? We're not looking at experience or knowledge. We know you've got all those things. What we are looking at is the human factors. For instance, hierarchy. What does an FY1 do when he's faced with a deterioration? He or she is faced with a deteriorating patient. Well, the reg might be in theatre and they don't want to call the consultant, or maybe a bit of ego depletion. Maybe they don't want to pass it on for seemingly being seen as not competent. What about HCAs to a sister? Does that delay in the treatment, etc.? So that's one thing in human factors. We also looked at teamwork. And I know I said teamwork isn't the be all and end all, it isn't, but there's lots of team strengthening we can do. The biggest thing in teamwork, we found something called kindness, appreciation. People really like that. And you might have seen a TED talk by Chris, what was his name? Anyway, if you have a look at this TED talk, he looks about where rudeness in teams can kill. And that's true. If someone's rude to you, puts you off and you don't talk to it or whatever. So how can we help surgeons with human factors? Well, we can look at a system which is more resilient for the inexperienced, supportive, proactive teams, help from patients themselves, faster, clearer communication, rapid access to key resources, minimal fear of conflict, systems to avoid process blockage or delay. They are coded in different colours because those are the interventions we put in. So let's look at the study. It's 5-year NIHR funded study, improves failure to rescue using human factors techniques. We're currently on work package 3. Work package 1 was just observing and analysing the current state. We did some human factors methodologies to find out what's going on. We co-designed the interventions with frontline staff. We're now on to the end of work package 3 when we did a pilot study in 3 hospitals, so Buckinghamshire, Stoke Mandeville, OUH and West Middlesex, and we're just about to go on to work package 4. And these are those 4 interventions we talked about: patient involvement, system redesign, team strengthening, shared ownership, and that's what we're going to talk about later. And I'm going to hand over to Peter.
Thanks, Laurie. So we haven't been able to look at what's in the box very much in that presentation. So maybe we can have some questions and later we can explain the individual strands of the intervention. What I'm going to do is talk about the reality of doing this. So we've got an excellent plan based on theory and on quite a substantial body of our own work. And now we've got some money, so we just have to implement it. Yeah, so I have to give a spoiler alert. This is not the most positive part of the talk, because I think implementing the pilot study has been one of the biggest challenges of my research career. And there are a few reasons for that. In 1960, somebody asked the Prime Minister then, what is the major factor that influences your strategy? And that's what he said: events, dear boy, events. And we've had a few. Almost immediately after we were awarded the funding, COVID-19 broke out, leading to a blanket ban on non-COVID research, restrictions on ward access, and massively changed patient flows. Post-COVID, we've been dealing with a period where the whole NHS is essentially in convalescence, leading, as we know, to lots of sickness and absence problems, increased patient pressure, and decreased morale. We've had a few other venues as well, as they say, not just COVID, but Liz Truss, the subsequent inflation, strikes in the health service itself, and war on the horizon. And all of these, including the war, have impacted the function of the health service significantly. And that impacts on the ability of health service staff to interact with an intervention like this, where we have to have daily communication with them. But that's not the only barrier. The infrastructure surrounding clinical research in the NHS is at the moment in a bit of a crisis. The approvals process takes a very long time, and sponsors reckon HRA approval just for the first 2 work packages of this study took 9 months. So that's 9 months to get permission to interview nurses and have focus groups. At the trust R&D level, I'm sure that most of the active research leads in the audience are nodding their heads at this point and saying, yeah, we know. The C&C process, which allows us permission to start a study at a trust, is very long, opaque, and difficult to speed up. And we've had our own problems with that, as have others. But it gets worse. There are contracts to deal with, which never used to bother me as a researcher, but now have impacted on some occasions on the ability of some sites to get on with the work. And it's interesting to note that the overarching contract for this study, which is between the OUH and the university, is still not signed, 2.5 years in. But perhaps the most egregious and difficult of the contract problems we've had is with honorary contracts for our staff. And the prize here, sadly, goes to Sachal, one of our researchers who's not here today, who waited 7 months for his honorary contract to work in OUH, and he's on a 1-year contract. This is, to me, the definition of dysfunctional. Once we got past all of those hurdles, we found that in some places, and I would stress that this varies, and we've had some very good experiences with very welcoming leadership, but some leadership were in bunker mode, made defensive by all the stresses of COVID, etc., and imposed extra restrictions. So in some places, we've been told we can't put up posters, distribute leaflets, access wards, communicate with staff, observe staff. We've had significant difficulties accessing the EPR to get the data that patients had consented to let us have. But perhaps the one that I found most bizarre was the reaction of information governance leads when we attempted to do a multidisciplinary simulation exercise. So the plan here was that we were going to do a realistic multidisciplinary simulation where we invented an avatar patient with a serious complication and kicked the whole thing off by getting the house officer to call radiology and ask for an urgent CT scan. And we were going to monitor the process all the way through and make sure that nothing untoward happened, but to get realistic reactions from the different players in the different departments. So these are some actual quotes from the emails I got from information governance lead in one of the trusts. I'm not going to tell you which. The the first thing they said was, I do want this project to fly, but we need to be safe. Fine with that. Next, we had a discussion about the patient's name. And as you can see, the governance lead wanted the patient to be called ZZZ Ether, but we can have an R at the front if we like. We thought this might possibly just give people a little clue that this wasn't real, and therefore we wouldn't get real reactions. So we came back with a counter proposal. I provided a list of Basque Christian names and Russian and Ukrainian surnames and mixed them up, and we had access to the NHS spine, so we could prove that no patient with that name existed in the NHS. The response to that was to suggest that maybe if we're going to do that, we better get the permission of the embassy of the country involved. So the Basques don't have an embassy, they're not a country, and Russia, okay. So then we were asked about what would happen if the patient died and the apparent impact on schedulers, pathology, palliative pathways. And this is a verbatim quote from the email. And finally, they wanted to know, would the simulated patient be pregnant, have HIV or a history of gender affirmation or a language barrier? At this point, a blank look was about the best response that I could sum up. But you can see that this whole process took several weeks. And in at least one trust, we still haven't got there. Finally, list of barriers, one more at least. There's dysfunction within the research infrastructure itself. The CRN are responsible for allocating research nurses, and research nurses are vital for this work because we have to screen and consent patients when they're very sick, when they've got complications. And research nurses are allocated only when trusts give the famous C&C permission, which I've said the process is opaque, heterogeneous, and very slow. So getting CRN nurses has been a struggle. In one case, we actually had to take money from the research budget and pay for our own. But there's a lack of coordination. When I looked to see what could be done about this, I expected that there could be a conversation between the head of the program grants program and the head of the CRN, or somebody at a slightly lower managerial level, to say, well, there's this coordination problem, can you help? Actually, no such mechanism exists in the NHR. Contrary-wise, there is a set of so-called reset policies currently going on, in which the NHR, who've suffered from enormous losses effectively from the delays from COVID, are looking at which programs they should close to try and recoup some of the money. So CIs like myself are looking over our shoulder as to whether we are considered to have experienced inappropriate delays. So I told you it wasn't the most fun part of the program. I am very proud of my team for having struggled through all of these difficulties, but I think we can draw some conclusions. And I think we need to look at this and call it what it is. The environment at the moment for this kind of clinical research is pretty tough. NHS frontline pressures obviously make staff engagement difficult, and Saydia is going to talk about that in a moment. But where leadership are defensive, that makes this much worse. I think the worst issues we're having at the moment are with back-off administration, not with frontline staff. In some areas, it seems virtually impossible to have a meaningful interaction with NHS institutions at this level. The NHR, not surprisingly, doesn't have the tools to respond to this kind of crisis. And my personal view is that they are going to have to get involved in a COVID-style prioritization exercise where they look at which studies they need to get behind and support rather than focusing on which studies they want to cut. So I'm going to leave that cheerful message with you. As I say, I'm proud that we've managed to struggle our way through all of this, but Saydia is now going to explain about the issues we have with staff engagement, because this is the key to all human factors and complex process interventions. If you can engage the staff, then you're on a winner. If you can't engage the staff, you have a big problem. Saydia.
Thank you, Peter. Hello, everybody. My name's Saydia. I would say I'd make my presentation very positive, but I think that's going to be quite challenging. Just a point to note, I took this job because I've got my PhD and I worked as an operating department practitioner. I've also worked in research for about 7 years, and I love my jobs. So I was like, well, I speak the language. So when I go into this project, all the nurses and doctors will relate to me. Unfortunately, that didn't really happen. But we did have some success and some engagement, which I'll talk about now. Just to start off, staff engagement is really important, as Laurie clearly said, and it's also so associated with staff well-being. What I found really interesting was nurses' retention is positively associated with staff engagement. Now, what's interesting is doctors' retention is associated with the retention of nurses. And then I've gone through all my work, well, some of my work experience, and I'm like, well, actually, yeah, we really support the doctors, and the doctors really support us. So it does make sense. But to have research which confirms that is very interesting. What's also very interesting is that having staff engaged enhances patient safety, and of course, patient safety is a key priority for us all. So some of the challenges that I faced, of course, were staffing levels. Whenever I've gone on a shift, whether it's a night shift or a day shift, this is when we're doing our site visits, they're always short-staffed. And oftentimes, you can't say, well, you're not short-staffed, but I'd wonder at times where I'm like, well, you're short-staffed, but everything's being done. And that's the great thing about healthcare staff. We have workarounds to get stuff done. Clinical pressures, of course, have always been there. So if you've not got winter pressures, you will have some sort of other pressures throughout the year, which I've learned. There have been COVID issues in terms of work patterns. This is very interesting. So when I used to work clinically, I would only do night shifts because it was where I functioned best. But if I made an appointment I'd say I'll visit next week. Would you like to come in? Sorry, Peter, somebody wants to come in. Right. So in terms of work patterns, I would agree to meet with someone the following week. And I'd go in, it's a drive from Oxford to this site, which is about an hour and a half. And sometimes I'd have to wake up at 5 o'clock, which Peter made me do. And we did that today as well. Anyway, I'd go all the way to this site and they'd say, Saydia, we were really short staffed, so we put them on a night shift now. And it'd be, oh, okay, that's great. It's fine. But I've driven all that way. So that happened quite a lot. Also, there were lack of opportunities. And what I mean about this is some people would show that they're really interested in becoming a response champion. They loved human factors, patient safety. And then we'd get all this work done. I'd meet the people because I love meeting people. And then they'd say, well, actually, they can't do this because they don't have time. Like the seniors would say, this person cannot be involved in the project, which was quite disheartening. But there's one thing I've learned from this project is do not take anything personal. And then remote work. Peter's got this theory that a lot of, sorry, Peter, I'm really naming and shaming you today. But Peter's got this theory that a lot of, sorry, FY1s in the room, a lot of the FY1s work only remotely. But this doesn't happen on every site. I'm sure it doesn't happen on OUH. But whenever I'd go into the ward, I'd see no FY1s. And then I made up this great term called avoidee, because whenever I'd go, they'd just be really avoidee, they'd just disappear. So that was the main challenge in terms of connecting with staff. There's also attitude and culture, which I kind of expected. So after COVID-19, staff felt quite deflated. So they had all these clapping and celebrations on a Thursday, which was great. But after that, nothing actually happened. So staff felt quite, I wouldn't say betrayed, but just disheartened. Like they expected a lot more. In terms of attitudes to management, I'm quite guilty of this. So if something irritates me, I would have my backup. And I saw healthcare staff doing that. So if they weren't in agreement with the management, they'd not cooperate with them, which did have an impact on our study. Something really interesting is loyalty to the team. So you have little cliques. So people connect with each other. And if one team isn't happy with the other, they will not engage at all. Which we had to find out through other people because people don't want to talk bad about their colleagues. There were leadership issues. So at one site, we've got a new matron. Staff aren't too pleased, so they literally don't want to talk to them, which is quite difficult. We've got a lot of people leaving. So if a leader leaves, so for example, at one of my sites, two nurses have gone with the old leader. And there's always this them versus us. So as I said, I think I'm a healthcare professional and I do a bit of academia on the side. So I thought, my communication is going to be great, but I was and I'm always an outsider because I'm an academic and I do not understand what they're doing. So even if I do a weekend shift, I go to site on Monday saying, oh yeah, I did a shift. It's like, yeah, but you don't understand our work, which of course we have to respect. So obviously I would ask people, how do you feel about Respond, just to get feedback. And this is the kind of feedback I got in terms of the resilient operating procedure. I forgot to mention, we've created something called a resilient operating procedure, which is a human factors based tool as a form of guidance. And it's more so checklist based. And the feedback that I've got from staff is, what's the point of doing this? We did get some positive feedback, such as, oh, this guidance is great. We'll put it on our monitoring machines, which is, that's effective. And the most fizzing quote I ever got was, I would rather people not escalate to me. And that's one thing I couldn't respond to because I didn't know what to say. Because I'm pretty sure escalation is a part of their job description, like being escalated to. So yeah, that was quite surprising. But I can't just make all of this stuff up because I thought, I'm getting emotional about this perhaps. And at times I did think I was making stuff up. But then I was like, I need evidence. So the evidence of the engagement challenges, of course, come from my experience, but we've also got evaluators from the University of Leicester who have done their own objective work, which does kind of coincide with what I've experienced. So an example of challenges is we've had serious patient safety incidents. So we had the death of a young patient on the ward. It was unexpected. And what they found was there was a lack of communication flow. So what we've been doing with the team strengthening strand, which is led by the wonderful Laurie, is we're pushing for safety huddles because communication is key. So we've relaunched, we've given them a protocol on how to do safety huddles. And it was like, no, we can't do this. It's too much work. We've gone to another site saying, why don't you implement what they do? It's only 10 minutes. No, can't do it. And then this incident happens and I get phone calls at various hours of night saying, this has happened. We need to implement safety huddles because we're being investigated. So of course, we're like, yeah, we'll help you out. But 2 weeks after, they found out that the patient had another disorder, which led to the death. So they were like, well, it wasn't our fault, so we don't need safety huddles anymore, which was a bit like, oh. We've also got a lack of engagement with the intervention. So my resilient operating procedure is on a little card. And I've got it online. So if I say, oh, have you seen the updated resilient operating procedure? And somebody would really excitedly say, yeah. And they'd show me a newsletter, which would really hurt because, I've really invested time into this. Although the surveys say, I sound like Bruce Forsyth, the survey says the ROP or the surgical escalation procedure is useful. So that's contradictory. Peter's mentioned a few challenges. We have leaflets to give to patients. They're not being given out. There's limited accountability, which is, we're trying not to laugh at this. So we, as a part of the patient involvement intervention, we have phones. At one site, the phone went missing within 2 weeks. We've got excellent e-boards, which are very effective on one site. But at one site, they've just not been welcomed. So the remote went missing. And now it's come to a point where it's just unplugged and turned around, which is quite, it's interesting because it's working at other sites, but not at a certain site. There's limited knowledge about interventions because in terms of feedback, if we ask to do like a structured survey, staff really do avoid it. And then something somebody really said was, everything is falling apart. So what I found was one person takes responsibility for everything, even though we have champions. And now, if God forbid this person goes on holiday for more than 3 weeks, we've lost the main contact. And this did happen at one site. So we did lose a lot of engagement when that patient was abroad. But what really did kind of hit home was nobody actually mentioned that they're going abroad, so we didn't know. And then, of course, there's a lot of staff absenteeism. Staff go off with stress. We've got lots of agency and bank staff. And then we still have COVID-19 sickness. So these are the challenges that we have faced. But the best thing is there are some sites that are engaging. And when I do go on site, there is awareness now since we've had and highlighted these challenges, which brings me to the end. Thank you very much. presentation because I hope that this presentation will highlight some of the positives that we've taken away from some of these challenges. So hi, everybody. My name is Olivia. I'm recently joining the team, the Respond team, and my full-time work is at Johns Hopkins Quality and Safety Department. So what do we do with the past 20 minutes of bleak outlook, based on our infrastructure, our organizations, our engagement? So we really recognize the need to have a multi-pronged engagement strategy. What do we need to do to address these challenges? And so first, we knew we needed to focus on leadership. Nothing is going to be accomplished if your leaders are not on board or if their beliefs and practices are incongruent with the beliefs and practices of staff. Second, we knew that we had to look at the interventions themselves. Are we really communicating what the interventions and their purpose and the asks that we have of people are related to the interventions? Do people recognize how the interventions meet the needs that they've identified time and time again? Are we clearly communicating that out to those folks? And then finally, we had to focus on the staff themselves. What do they need? What is their incentive to participate at all, given the challenges that they are also facing? I'm sure if we did a grand rounds related to their own challenges, they would have 30 minutes of challenges that they're facing. So how can we make sure we gel well with both what we're trying to do to accommodate some of these needs, as well as making sure that we're addressing some of the needs that the staff have identified and some of the challenges that leaders are facing? In this, again, we had to develop a very multi-pronged engagement strategy, hitting on all of these points. And so I will say, although we have expertise in a lot of areas on this team, we do not have a lot of expertise with, how do we better engage and communicate? And so we really had to look at, well, who are these experts? So we went to political campaigns, we went to, health communication experts, we went to behavior change experts, we went to consumer psychologists, and we really tried to pull in what are the best practices for, behavior change, even related to social media. So really, this is kind of, highlighting on the point that if we're trying to overcome a challenge as seemingly insurmountable as staff engagement, we can't do it with the tools that we have in our typical toolbox. So the first thing that we did is listen, and we developed structures to continue to listen. So we really had to make sure that we were acknowledging the human side of change. And so I wanted to really focus on managing complex change here, because as you can see by this diagram, if any of these components are missing, the outcome will be one of the 6, outcomes that are listed there. This diagram is very helpful for us because we were able to look at this and really pin down, as we're hearing things from staff, as we're listening to staff. Is it a lack of vision? Is it that they're lacking skills to engage with Respond? Is it that they're lacking incentives? Is it that they don't have resources? Do they not understand our action plan? And this really helped us hone in on, okay, what are we missing here? And how is it relating to the outcome that we're seeing, anxiety, resistance, etc. We also have to recognize that we are one part of the staff's working day and one part of that organization. So we really had to be strategic with what we're listening to and to whom we are listening. So we looked at essentially, how does the organization itself function? What are the reporting structures? What are the committees and meetings, and who is onboarded and when, and what does their onboarding look like? So we really had to make sure we understood the organizational context, how we fit into that, and how we could address some of their strategic priorities and their KPIs with the introduction of Respond. And then finally, to get really granular and to make sure we really had structures to understand the timely needs of staff, we introduced cake breaks. So these are exactly as they would sound. We sat down in a room where there was an amalgamation of staff, nurses, doctors, and we listened to them and we had conversations with them and we said, how are you feeling? What's going on today? What are some of your challenges? And we did this iteratively. Of course, we were taking notes in a very structured way on the side, but we tried to make this environment something that was a little bit more informal. So then the second thing we did is we developed a core message and brand. So this is very straightforward. This is what any organization, team, product will do, is we really had to make sure that our communication materials, our engagement materials were recognizable. Do people recognize Respond when they see a newsletter or when they see the ROP? Do they understand what we're doing by just a quick tagline? So this is just one of the materials that we've produced to develop the core message and brand. And again, like any company would do, Nike or Adidas or Starbucks, we iterated multiple times using different sort of segments of this, branding boilerplate. And I worked with Luis a lot on this, so I appreciate it. Okay, we also provided an answer to why should I care? Why should I interrupt my workflow and engage with Respond? This is key. We have very limited resources, and as we just mentioned, morale is significantly down. So if there's not an answer to why should I care, you're not going to get engagement. So we did this largely in 3 ways. These are just 3 examples. But first, we provided quotes from those who did engage with Respond, those who were champions. And we got those quotes to say, here's what some of your peers are saying in a very positive way. We also provided a tangible incentive. So we provided incentives for, for example, for FY1s to lead a quality improvement project as is part of their curriculum and their development. Of course, nurses could also engage with these quality improvement projects for part of their CPD. This is something that, we have a lot going on within Respond, so it's very easy for us to identify some projects that we can carve out and guide people through the quality improvement process. And then finally, we know that we're hearing the needs of everybody and we're working to address them as a team. But do they know? Do they know that we're hearing them? And do they know that we're working to put things in place? So we had to overtly say, we heard you, and here's what we did about it. Here's what we heard, and here's what we did. And then finally, again, taking key core components from political communication, health communication, consumer psychology, we had to iterate this multiple times, multiple ways for multiple different needs. So informed by the structures that we put in place for continuous listening, we developed a breadth of communication material. So first, we heard from leaders that, I don't really know what my role is within Respond. I don't know where we are. I don't know where these updates are coming from. We developed a weekly, sometimes bi-weekly email for those leaders. 1 page, here's the key update that you need to know about Respond this week. We developed our newsletters for frontline staff. But again, the difference here is that 1 page, key updates, and you have our Respond branding right there. I'm going to skip over the middle part because that's the best part, I would say. We also, again, kind of listening to their organizational structure and how people were onboarded. We looked at that and said to our nursing educators, hey, is there any way that we can integrate Respond into your nursing onboarding? When are nurses onboarded? What does that onboarding process look like? So we developed a 1-pager for their education material with those nursing educators to say, here's what we want, the key message that we want to get to new nurses, particularly new nurses, as they're the ones who might benefit most from the Respond interventions. And then finally, for our leaders, again, some of the leaders were saying, what do you want me to do? Tell me exactly what you want me to do and I will help to do it. And so, for example, we developed very clear, actionable material for our leaders to say, or in this example, here are our values of the day. Here's how we want you to actualize these, within your rounds or your leadership meetings or your committees. Here are some ways that you can actualize these values in your work. And then in the middle, this was probably our most impactful intervention for a few reasons. 1, because it was kind of shiny and a new toy on the unit. 2, because it was ever changing. And 3, because people saw themselves on it. And that was our e-board. So the e-boards, as you would imagine, are about yay big, and they constantly autoplay a series of about 5 slides or so. This is important because staff could see themselves. Staff could see positive comments that others were leaving about them. They could see how some of the other staff were using the values stickies. They could see key updates about Respond. They could scan QR codes to give feedback there. And again, true to core principles of just advertising in general, we constantly kept this updated and we made sure that what we heard from staff was represented here. Now, although this is my last slide, I want to emphasize that we are not done. Those challenges are not going to be addressed by an e-board or an email. And so we have spent the last, I would say, several months putting structures in place to better inform what we're going to be doing when we leave these pilot sites and go to the other sites who are going to be brand new with Respond. So I think we've taken away key lessons learned, and we're ready to hit the ground running with these key lessons as we're expanding into other hospitals, which we'll talk about in a moment. Thank you.
Hey. Well, I think all of you can see that Olivia is a bit of a force of nature, and she has absolutely revolutionized our communications since she joined the team. So thank you very much. And hopefully things move on a positive note, because we're going to talk about results now. Before I show you the results to date, I just wanted to explain what it is we're measuring. We were looking for deteriorating patients and the rescue response, and we had to very clearly define what we meant by that. So we defined an event as beginning when a patient who's undergone some surgery, one of these things happens to them. The MET team in these slides refers to the critical care outreach team where one exists. And then the end of the episode, so the beginning of the episode is when the first note of an emergency or an alert is made, and the end is when a note is made of a decisive management action to address the deterioration. So having heard some of the challenges and struggles, you won't be surprised that we were a little apprehensive about looking at our results. But Sachal produced the first batch about a month or so ago, and he divided the results into 3 epochs. First of all, we did 3 months of observation on all the sites before we introduced the intervention in March last year. Then we had a 7-month intervention introduction period, followed by a sustainment period. And he was asked to compare the 3. And the primary outcomes we're measuring are the quality of the response as scored by an independent senior surgeon. We divided the response up into 6 segments for that, and the timing of the response according to the timestamps I've already mentioned. So this is the quality of response results, and I was pleasantly surprised, to be honest, to see that we had an uplift from the intervention of around about 15% on average. There was a significant sag back during the winter after October 2022. And I think anyone who thinks back to the winter we've just had can appreciate that that is an actuarial trend, that in a health service that was collapsing before our eyes and the focus of the media every day, it wasn't surprising that we had some fallback. 15% may not sound huge, but this was scored on a Likert scale between 1 and 5. And those of you who've done research using those know that nobody ever uses 1 or 5. So you tend to get a very beige result. I was quite heartened by that, but even more so when we saw the results for speed of response, which we have almost halved. And this is now, I think, based on all 3 trusts. We didn't have data on the 3rd one till recently. And you can see that the sag back in the winter doesn't really occur here. This gives us a great deal of confidence that actually, despite all the difficulties, we're doing something. And that means that we can think to the future. And the future, as planned in Work Package 4, is a 24-hospital randomized trial. The plan is to take this to hospitals using what's called a cluster randomized step wedge design. The step wedge design means everybody gets the intervention because everybody wants it, but they're randomized to receive it either earlier or later. And we're going to do 6 clusters of 4 hospitals each. They'll all get a 3-month intensive induction phase with the 4 strands of the intervention, and then a 6 months more light touch maintenance phase when we'll be calling in regularly to check that everything's going okay. The primary outcome this time will be failure to rescue, which is defined as the percentage mortality for patients with complications. And the secondary outcomes are going to be post-operative mortality as a whole, length of hospital stay, intensive care use, and recovery in quality of life after the event. So we're set up for that, and we're trying to recruit sites. I think we've got about 15 of the 24 we need at the moment. But as I say, there's a little bit of a race against time going on with the requirements of the NIHR. We've also had some spin-offs, and this is one of them. The Chelsea and Westminster Hospital were so enthused by Saydia's work on the surgical escalation procedure that they've adopted it with their critical care team and want to disseminate it through the hospital. And they also want to join our main study. So having a big influential teaching hospital like that on board is quite a help. There are also some other important conclusions to be drawn. I think this has thrown up a lot of new research questions. In human factors, we start by thinking, well, here's an intervention that makes sense and it'll help. And then you realize that you have to deal with staff engagement, and then you have to deal with the local environment. And then, as we found, you have to deal with the infrastructure supporting that. So it becomes a bit of an onion problem, you might say. Why is engagement so difficult? Well, we still don't know enough, I think, about the factors which influence staff either to really get engaged or to look the other way. We really need to understand engagement. It's the holy grail of this kind of work. A lot of people who've never tried human factors work say, well, you know, they're all doing that anyway. And we say, well, no, they're not, actually, if you look at the data. And our aim is to try and make sure that services are delivered reliably as they were intended all the time. To do that, we need staff engagement and we need to understand how to optimize it. We don't know what the limit is. We can't expect everybody to behave like robots and do everything we say all the time, but we are sure that there's important research to be done on how to get as many people on board as possible. One thing that has been highlighted by what I was commenting is whether the environment in which everybody works is a major factor in that. Well, of course it is. But the question that's been front and center in my mind is whether the current state of the NHS management structures and their functionality is having an impact on the attitudes of staff on the front line, and whether we could do comparisons with other organizations with perhaps leaner and more nimble management pathways to see if we can learn from them and actually produce a bit of a top-down cascade where improved management leads to improved engagement on the front line. The type of research that would be needed for that involves collaborating with people like big data analysts and people in the business school and qualitative studies with staff. We're very interested in taking this forward in the future. But first of all, we have to get the randomized trial done. As a surgeon, I think human factors is a natural match for surgery because all surgeons through their training develop a perfectionist attitude. We know perfection is impossible, but we can strive for excellence. And squeezing down the variance between the excellent and the average is an excellent way of producing better outcomes for patients nationally. It's also likely to be more cost effective. And excellence is a holistic concept. If you take the analogy of an athlete, the athlete doesn't just run or train, they also take care of their diet and their sleep patterns and their psychology and multiple other factors, anything that's going to give them that little extra edge. And I think as surgeons, it behoves us to take the same approach. We should be looking at anything that can help us to produce better outcomes for patients. And I was very influenced by my time as a trainee in Japan. They have a couple of words for this, which you might want to go and look up. But I would propose human factors research is a key element of how we should be trying to improve our practice, and ask you, if not that, then what? So thank you very much.